Welcome everyone to Chicago Autism Network's virtual parent workshops. Tonight, we are very fortunate to have Dr. Rhiannon Law presenting to us. Dr. Law is a pediatric neuropsychologist from North Shore Pediatric Therapy, and I will turn the time over to her.
Okay, great. Let me share my screen real quick. Okay. Okay, so like Kimmy said, thank you. I'm excited to be here. My name is Rhiannon Law. I'm a pediatric neuropsychologist at North Shore Pediatric Therapy. So today we're going to talk about the comorbidities of autism spectrum disorder. So we'll get kind of more into that. So the plan today is we will kind of generally go over what is pediatric neuropsychology, what does it look like, and kind of answer any questions you guys have about testing in general, but really delve deep into kind of what are the comorbid diagnoses beyond autism that you can kind of expect your child to maybe come across, or other concerns that you guys have in terms of diagnosis and testing in general. Real quick, we don't have any financial or kind of conflicting interests with this. So we are obviously sponsors of the gala, which is exciting. I hope everybody is able to attend. But otherwise, we're just doing this to kind of help with the community. A little bit about me. I got my PhD from Indiana University. I'm a licensed clinical psychologist in Illinois. I completed a 2-year fellowship specializing in pediatric neuropsychology after working in a couple of hospitals, schools. I've worked in foster care. So I have a lot of experience in a couple different areas. Most relevant, I have some clinical interests related to autism. So I was a part of a multi-million-dollar National Health Institute grant-funded project looking at joint attention-mediated learning in toddlers with autism. So I looked at how we can train parents to be kind of behavior therapists, and how we can help parents promote things like joint attention, which is a really good predictor for response to treatment for kids, and especially toddlers with autism. So looking at things like eye contact and how parents can really promote that in the home beyond ABA. So I was a part of a big project like that. Clinically, in my day-to-day job, I am obviously a pediatric neuropsychologist. I do a lot of testing. I particularly am interested in looking at early identification of autism, developmental disorders, and other kind of neurodevelopmental disorders. So looking at early identification in toddlers, as well as obviously the comorbidities and other diagnoses. Otherwise, I have a lot of experience working with ADHD, medically complex cases, so kids who have epilepsy, cerebral palsy, other types of disorders like that. So a lot of broad experiences, but autism has definitely been a kind of a special area I've close to my heart for a long time. So a lot of experience with these kiddos. So generally, I kind of want to start with just what is pediatric neuropsychology. So the neuropsychology part is that we are psychologists who go through extra training to really look at cases through a lens of the brain. So we get extra training looking at, brain development and how that impacts typical child development. We really want to look at the interplay between brain development and just general behavior day to day. So we focus a lot on the abilities of your children. So the true abilities in terms of what could they do in the best situation, looking at, their highest potential if we're really able to get them in the kind of the perfect one-on-one situation, but also looking at day-to-day functioning. So, in reality, what are the kids actually showing you at school, at home, in the community? So looking at both of those, because those are both really important parts of, your child's potential, but also kind of what we're dealing with in reality. The pediatric piece is that obviously we are focusing on children. So really focusing on neurodevelopmental disorders. So things like autism, ADHD, learning disorders, cognitive impairment, language impairment. So typically the things that we would see under the age of 18. So generally, that's kind of our specialty, is those neurodevelopmental disorders, looking at just kind of, again, typical developmental steps, milestones, things like that. We really want to look at it across kind of the typical, the context of typical child development as well. So we have a lot of experience in a lot of different areas, which is why we're well suited for this type of evaluation. So generally neuropsych evaluations go across kind of these 3 steps. So the first appointment is usually an intake. So this is really gathering the developmental history, looking at the symptoms. So this is a meeting with the parents to look at kind of what are the concerns that you're bringing to the table. So you may already have a diagnosis of autism and now you're wondering, are there other concerns like ADHD? Are we having some learning impairments in school? So this is where we look at what is the question you're asking? What do you want us to answer? And can we answer that for you? So it's a conversation. We really want to get that developmental history. We really want to, again, get all the data that we can get in terms of answering questions. The second step is the testing appointment. So that would be kind of the bread and butter of our data gathering. So this is an individual battery. And by battery, we mean a variety of tests. So this is where we do the specific battery unique to your child, obviously, because every child is different. And they're all standardized. So we're looking at in kind of the comparison again compared to other kids, their age, their gender, kind of looking at that development. And we want to get as much data. So the testing gives us a lot of data of that kind of true potential. What is your kid capable of in kind of this one-on-one, really intense setting? That what kind of can we get out of them in this perfect situation? But we also have you fill out forms, we have teachers, we have therapists fill out forms. We want to, again, gather as much data as possible across settings because we know kids can act differently across a couple of different settings. School might get one behavior, you're not seeing that at home. So we want to, again, get as much data as we can get for you guys. The third appointment is the feedback appointment. So this is where we're discussing the results of testing. We're talking about diagnosis. We're having conversations about recommendations based on that individual profile. So that typically is kind of the way testing is conducted. So that's kind of how we do our data gathering process. So when I say battery, again, I mean kind of an individualized set of tests. So we have dozens and dozens of tests, different ages, different presenting concerns, different areas of data. Obviously, they're not all appropriate for every kid. So based on the intake, we want to ask questions, how verbal is your child? How long can they sit still? What are the concerns you're having as parents? If you're having more concerns with reading, then we're really going to pull a lot of reading tests as part of their battery. And like I said, battery is just that they're unique collections of tests. So typically, the areas that we would be able to look at in neuropsych testing. So cognitive ability, so kind of the classic IQ, looking at intellectual functioning, looking at a profile of kind of verbal skills, visual skills. So this is a really important area, not just to get an IQ score, that's one number, but I really want to look at that profile. Where are the strengths, where are the weaknesses, processing speed and working memory. We look at a bunch of different areas. We also obviously look at academic achievement. School is a kid's job, so it's really important that we look at reading, math, writing. We're not missing any underlying learning issues, but even breaking it down. Academic skills, looking at their fluency, looking at their comprehension. Are they understanding, even if they're able to memorize things, are they able to understand the deeper areas? We want to look in those areas. We look at attention and executive functioning. So executive functioning is things like organization, planning, impulse control, multitasking, a bunch of different areas like that just get harder as kids age as well. We look at memory, so visual and verbal memory. We look at language functioning, both nonverbal and verbal language, in terms of eye contact and that kind of thing as well. Expressive and receptive language. We look at fine and gross motor skills, and obviously social, emotional, behavioral functioning. So mood, those developmental milestones that we're talking about in terms of behavioral function. So really a good breadth of information. We want to get, depending on what the presenting concern is that you guys have as parents, we want to get that, these are our skills to answer those questions for you guys. We get as much information as we can get in these areas. If it's not a concern, it's not the focus, but we're still going to try to touch on it for you. And also go into depth. If you have particular concerns about mood or executive functioning or attention, we have a lot of really finely tuned sensitive instruments that can get us a really good depth in these areas as well. So that's kind of what the areas of testing we look at. So really, what can testing do for you guys as parents? And really, how does it help us with kids with autism? So every kid is unique. You guys know that there's not one kid. Autism is not one disorder. Every child is going to present with a different myriad of symptoms. They may have, more severe repetitive behaviors, but better social skills. Every kid is unique in the way that they present with their symptoms, but also outside of their symptoms. Your kid is a kid outside of being autism as well. They're going to have their own profile of strengths and weaknesses. It is a spectrum after all. There's going to be a wide range of presenting concerns. So really testing is a good data gathering process for verifying diagnoses. So like I said, autism, we're here to talk about those comorbid diagnoses. So that's going to be a big part of this, but also just generally looking at the strengths and weaknesses. We want to look at every kid is going to have things that they're good at, things that are a bit more difficult for them. And even if it doesn't result in another diagnosis, that's helpful information when we talk about recommendations and treatment planning and their IEP. And we talk about what kind of strength, what kind of supports they're going to need in a couple different environments. So that individual profile is really important when we then talk about recommendations, because then I have the evidence as a neuropsychologist. I can say, this child has a weakness in these visual spatial skills. Here's why I think they need these specific accommodations in their IEP. And that really gives us the data. It's not just kind of my opinion, your opinion. It's looking at that individual profile. And that profile does tell us, are there other diagnoses going on? Can we make sure that we're treating the whole child? We're not just treating the symptoms of autism. So specifically for children with autism, testing is helpful. Ongoing testing is helpful because we want to see, are they responding to the current interventions? We should see improvement over time. If your child is participating in ABA or in speech therapy, occupational therapy, there's so many different options out there for kids depending on what services they need. And we want to make sure that they're showing that progress, that they're making strides in the areas that we're looking at, and also that we're not missing an area. Like I said, kids are still kids outside of being autism. There's other concerns that might be on there, and we want to make sure we're addressing everything and we're not missing a piece. Also, like I said, we specialize in neurodevelopmental disorders, and kids are constantly developing. A 3-year-old can be so different from a 5-year-old, from a 9-year-old, from a 13-year-old. There's huge developmental gains that kids take throughout and big steps they take throughout their childhood. And we want to make sure that we're monitoring that. We want to make sure that, the way that your child presented when they were 3 or 4 or 5, when they may have been first diagnosed, versus the way that they're presenting now when they're, in middle school or high school, that's going to change over time. And really having better data makes us have better decision-making abilities. So that change over time is really important. They're going to acquire new skills. They may seem like they're plateauing, but really we want to make sure, are they just plateauing because we're comparing them to typically developing kids, and maybe they still are making progress, just slower, or are they making huge jumps? Like, there are days kids wake up and they suddenly feel like they've taken 10 steps forward, and that's great. So testing over time is really important. We want to make sure that we're constantly monitoring it, because we want to make sure that our treatments, we can fine tune them so that we're really making the best bang for your buck. You guys are spending a lot of time and money in these therapies, and we want to make sure that you guys are really effectively using that time with the child. So like I said, for example, if a kid has, say we do testing and at the feedback, they have a weakness in social skills, they have a really strong strength in kind of verbal ability. They're very verbal, but they're really struggling with social skills. So maybe at that point we talk about, great, let's add on some group therapy. Let's add on some sort of group interaction as part of their therapy, because they're really verbal, but we need to work on these kind of in a structured social environment. So again, there are a lot of kind of strengths and weaknesses, and we wouldn't necessarily know that without the testing and having that data to sit down with. So again, just a really good area for data gathering. So what are comorbidities? So it's basically the fancy word for a common co-occurring diagnosis. So it means that having been diagnosed with autism, there's an increased likelihood that you're going to see these other kind of common secondary diagnoses as part of it. So a lot of comorbidities often mimic the symptoms of ASD, and so they're often overlooked. So a lot of kids, with autism sometimes are pretty hyper and have a high activity level, but some don't. And so a lot of times people will kind of look at that and say, okay, that's the symptoms of autism. And it might be, but also it's important that we get the data to say, are we not missing something else that's going on here with this child? A lot of kids who have autism may kind of blank out and stop responding. And we know, not responding to your name, not responding to things, classic autism symptom, right? again, could also be an absence seizure. We want to make sure that we're not missing something like seizures that are happening, because that's obviously an incredibly important thing we want to monitor. So there's a lot of different areas that I think are important to monitor in this. And we need to actively look for them for testing. Because like I said, it's hard to tell just from looking at a kid whether this is an autism symptom or this is something else. Testing is really sensitive and can differentiate, the difference between, an autism symptom and another symptom. And that's the importance of all this data gathering. Similarly, I mean, kids present differently. Females with autism tend to be slightly more social, slightly more verbal, usually have kind of one friend they're able to make. They sometimes will have atypical restricted and repetitive behaviors, and are underdiagnosed or diagnosed later, whereas, boys tend to have more behavioral presentations and have kind of more classic restricted repetitive behaviors. So again, we need to make sure that when we do this testing, we do it in a way that is purposeful and in terms of looking at making sure we're not missing something. So first, we'll kind of go through the common diagnosed initially. So when you first get diagnosed with autism, there's a couple of different areas that are typically looked at as well, but obviously I don't want to skip over them. So often the first diagnosis is a pediatrician or an early intervention specialist. And the question really is at that first evaluation or first meeting with your pediatrician, does my child have autism? That's the big question. So typically that's the focus. We're not necessarily looking at secondary issues. So with that, typically we'll look at that cognitive processes. So we'll look at, is there a cognitive impairment, looking at intellectual disorder? So 20 to 30% of children with autism have an intellectual disorder. An intellectual disorder is looked at by obviously evaluating their IQ. So again, that's composed of a lot of different areas: verbal skills, visual skills, processing, working memory, problem solving. So IQ isn't just a single number, it's composed of a lot of different indices that go into it. And kids with autism tend to have a very uneven profile. Really strong visual spatial skills, but really weak verbal skills, or vice versa. It just tends to be very inconsistent, because a lot of this is related to, some of their, restricted interests. A kid may be really into memorizing the dictionary and remembering letters, and that's their interest. They're going to look very verbal. But when we look at kind of their visual spatial skills, they might be a little bit lower. So looking at the cognitive impairment is important. Because early intervention is really important. The second part of cognitive impairment evaluations that is beyond just IQ, because IQ is just a number, right? But we want to look at adaptive skills. And adaptive skills are activities of daily living. So that includes things like communication in the real world. That includes things like being able to, do their hygiene routine. That includes socialization. That includes being able to kind of do their just daily living skills, feeding themselves. Recognizing the community safety standards. So, are they running in the parking lot? Well, it's adaptive skills, and it's that intellectual, that IQ related to kind of those true skills. So again, you see that interplay between, we want to look at kind of these true abilities. We also want to look at, in the day-to-day functioning, where's the impairment at? Are they able to compensate? Because if they may have a lower IQ because, we're not able to test it accurately, but if those adaptive skills are high, that's not an intellectual disability. So it's two pieces. So you always kind of see that interplay in testing of true ability versus kind of what are they doing day to day. So that's kind of the first area typically developed when you kind of initially diagnose autism. The second area is language. So as you know, language is tied incredibly highly with communication and socialization, and those are huge parts of autism. So a lot of times there is a language impairment associated with autism for younger kids, especially. So 25 to 50% of children with autism do have some sort of disability, some sort of language limitation. It is kind of a huge spectrum. There may be kids who are completely nonverbal and will never use language to communicate. There are kids who are almost hyperverbal and will over-intellectualize, and they can be overly formal in the way that they talk, and they have these massive vocabularies, and it almost is harder for them to socialize because they are using a vocabulary that's not appropriate for their age or their developmental level, or they over-intellectualize, or they learn these really specific language for whatever their restricted interests are. Being really into science and then using really scientific terms and the Latin names for everything. And so that's a really overly formal way of communicating. Obviously, with autism, we want to look at things like echolalia, which is when kids repeat. So if you say, "Hey, look at the dog," and maybe the little kid goes, "Dog, dog, dog, dog." So that's that immediate echolalia where they're repeating things that they're saying right away. There's also delayed echolalia, which is called scripting or stereotype language. So sometimes they will have a show that they really like, and they'll remember phrases and parts of speech, and they'll kind of use them later in their play. They may use them appropriately, they may use them inappropriately. A lot of times there's songs from TV shows, there's certain dialogue or catchphrases that catch their attention. So that kind of scripting, or kind of learning certain phrases, and that kind of, it's really not flexible speech. They're not really communicating flexibly with you or fluently. They're memorizing phrases. So sometimes they can even be phrases they've memorized from speech, and they're using them appropriately and they're communicating, but they're not flexible. They'll kind of just learn them. We also want to look at tone. So having an odd rhythm, so being jerky or halting in the way that you're talking, looking at the tone of, are they really flat or over exaggerated, or really sing-song in the way that they're talking? So looking at that quality of their speech as well is important. Again, just generally looking at expressive versus receptive vocabulary. So, a lot of times parents will say, they seem to understand a lot more than they're able to express when they're talking, and that's incredibly common. But also looking at, are they understanding as much as we think they're understanding? Have they just kind of learned what we wanted? Looking at that both those expressive and receptive language skills is really important. Even if language is generally intact, sometimes kids with autism have a hard time communicating their needs. So things like requesting things, having their needs met, so just effectively being able to get your attention, tell you what they need in a way that makes sense, and then kind of being able to wait for that and being able to have that back and forth dialogue. An area that is typically a weakness for many kids is social pragmatics. So social pragmatics are an area of language that looks at basic social skills. So being able to understand things like metaphor, non-literal language, and inference. We use a lot of inference when we talk to people. We kind of talk around something, or we leave part of it out and assume you can fill in the blanks. And just recognizing social skills and being able to pick up on some of those verbal social abilities are really important. So those social cues of, sarcasm, using like metaphors. Oh, I'm feeling really blue today. That's something that we take for granted understanding. So those social pragmatics are really important. So even if language is generally intact, we want to make sure that we're looking at all parts of language, not just simple spoken language. And then obviously, nonverbal communication is a big part of language as well. So being able to integrate things like eye contact effectively, facial expressions, gestures. Are they, using their hands to communicate? Okay, I want 2 of these, or I don't really know, or shrugging. We always kind of emphatically use our hands when we're talking. So integrating those nonverbal communication skills are also a part of the way that we communicate. And are an important area that we want to look at when we look at kids with autism, because all these areas are, again, it's a huge spectrum. So we want to make sure that we're doing a really detailed evaluation so we can look at all these areas, not just, okay, how's their vocabulary? We want to look at how's their reciprocity in their conversations. Can we have, a back and forth conversation about something, or are we question, answer, no more response? Are we just answering direct questions and not really engaging in any conversation? So again, these are all areas that neuropsych testing is looking at as well. And again, should inform our treatment. Obviously, our speech language pathologists do an amazing job at evaluating this, but sometimes it's important to kind of get updated, broad evaluation to see where things are at. The last area that's kind of a typically at first diagnosis, we look at kind of fine or gross motor skills. So this is one that up to 80% of kids with autism will struggle with having kind of some sort of fine or gross motor deficit. So gross motor means kind of the big, large muscles in your body. So things like balance, holding your trunk up as you're sitting, kind of general clumsiness. Are they bumping into walls? Are they tripping over things? Fine motor skills tend to be kind of what we call kind of more hand-eye coordination, grasping things, picking things up, zipping, using utensils. Some of these are related to kind of the sensory concerns related that are a part of autism. So a kid may have a hard time just with some of their sensory processing issues, which I knew you guys, there was a presentation recently about that you guys went into more depth. But definitely those kind of sensory experiences or restricted and repetitive behaviors as well. Sometimes kids will be, hand flapping or engaging in these really strong motor rocking back and forth and have a hard time with some of that trunk control piece. So definitely meeting those early milestones for just general motor development can be difficult in a lot of kids. But like I said, a lot of these are going to change over time. Cognitive skills are not kind of considered stable until a kid is about 8 years old. So even if you do early evaluations and there's this kind of interesting up and down profile, that's not really considered a kind of stable construct until kids are about 8. So it's really important that we monitor that over time because that's changing based on the environment. Similarly, language should hopefully be something that's changing over environment. Typically developing kids go from a couple words when they're young, to huge vocabularies and communication abilities when they're older. So again, we would expect the same. We want to see growth, we want to see issues, and we want to make sure that we're monitoring that over time. And similarly with gross and fine motor skills. So some typical ones that aren't necessarily evaluated initially. So one of the more common ones we see in neuropsych is mood disorders. So what we mean by a mood disorder is like anxiety, depression, bipolar disorder. So these are kids who have a really hard time with emotion regulation. And again, that's a lot of kids. So starting with anxiety, 40 to 60% of children with autism do present with some sort of presentation of anxiety. The most common being social anxiety. A lot of times, kind of higher functioning kids become pretty self-aware. So if you have an adolescent that starts to recognize that they're experiencing things differently, they're having a hard time socially, that's a really big risk factor for developing something like social anxiety. Also generalized anxiety, stress-related disorders, even obsessive compulsive disorder, it has a higher base rate in autism. So these are higher than the typical population. So again, when we say those comorbid diagnoses, kids with autism are at a higher risk than kids without autism for these disorders. A lot of times with autism, anxiety can be triggered by the symptoms of autism. So for example, a lot of times kids with autism are pretty rigid and almost have an intolerance of uncertainty. So they don't really have a great ability to tolerate situations that are uncertain or have a lot of ambiguity, kind of those gray areas. And already that makes humans in general a little bit nervous. And I think, kids with autism are particularly primed to find those anxiety provoking. So that's why it's at much higher risk for kids with autism. Again, like I said, adolescents, as we know, when you're in kindergarten, you can ask a friend, hey, do you want to play on the swing set? And your friends. Middle school, high school, friendships aren't that easy. Making and maintaining friendships through middle school, high school are a lot more complicated. The social situations are a lot more complex, especially with the age we're in with digital kind of engagement and having texting and I don't even know TikTok and all that. I don't even know the apps anymore. But having all of these interactions, they get more complicated, and I think that puts kids with autism sometimes at a disadvantage in terms of keeping up with those social skills. So being able to be aware of that is important. Especially sometimes kids who have difficulties with adapting to changes or transitions throughout the day can find a disruption of their routine very anxiety provoking. So that's a big part of the anxiety that kids with autism sometimes experience. Sometimes there's difficulty recognizing kind of affective states of others. So recognizing when other people are sad or happy or experiencing things can make it hard for kids to know how to react in that situation. And that kind of overwhelming bodily sensation. So sometimes there's just a physical side of anxiety where, you're overstimulated and you're experiencing a lot and it's making you anxious. So anxiety is definitely one of the bigger kind of referral questions we often have, especially as kids are entering adolescence and high school. So that's a big one to keep out for as parents. In terms of depression, it's higher risk if you have a higher cognitive, so higher IQ, and if you're older. A lot of times there's an experience of kind of being isolated or withdrawn. It tends to be related to social rejection, sometimes teasing or bullying that sometimes kids experience, kind of just lower self-efficacy, so just not really believing that you can do as much. So all of those are related to concerns with depression. So with kids who are pretty verbal, they may express hopelessness, they may express these concerns in terms of being sad, isolating themselves, increased fatigue, just verbalizing that they're feeling left out, feeling bullied. For kids who have limited verbal skills, it's a little bit harder to determine if they have depression. But there's been some research that there tends to be increased self-injurious behavior, decreased self-care. So it looks like almost a regression in some of those adaptive skills. Just labile moods, so being up and down and having a lot of dysregulated mood is important. One of the big symptoms of depression in kids, just generally, even without autism, is irritability. So if there's any kind of increased irritability that you're noticing, a decrease in their special interests. So even if they're losing interest in something that previously was something they were pretty passionate about, is usually an indicator of depression. And just a general regression of skills because they're starting to lose motivation. So those are some of the kind of more behavioral symptoms that we tend to see for depression for kind of the more nonverbal youth. So again, these are the big areas. We want to make sure that we look for these on purpose, because especially if there's limited verbal skills, these kids aren't necessarily saying, I'm anxious, I'm depressed, I'm having these mood symptoms. We want to make sure that as parents and as providers, we're monitoring this, we're collecting the data to make sure that we're not, again, missing a piece of this. A kid may seem like they're hitting a plateau in their treatment, and we're wondering, what can we add on? What's going on? Why aren't they making their goals? We kind of forget that outside of autism, they're experiencing these mood, they have these emotion regulation pieces as well. So again, really important to monitor. Similarly, the kind of classic learning disorders. So a math learning disorder, reading disorder, or writing disorder. Their medical names, dyscalculia, dyslexia, and dysgraphia. So there's not a particular profile related to autism. There's a higher risk. It tend to be related to that uneven profile of cognitive skills. So, a kid who is really into puzzles, and that's kind of part of their restricted interest, is those visual spatial skills and puzzles, are probably going to have pretty strong math or other visual learning skills, may struggle more with reading if they have a harder time with verbal skills. So again, that profile, when we talk about the cognitive profile and the general profile from neuropsych testing, is really important, because that's obviously going to impact their learning and what they're doing at school, because they're naturally going to do activities that they find engaging and fun and that they're good at. And so kids who do well on things usually have a really good interest in it. But a lot of times kids with autism have a hard time faking that interest, and if it's not something that they care about. So those skills tend to lag behind. So sometimes there are these kind of concerns with academic skills, academic fluency, and comprehension. A lot of times higher order kind of reading comprehension is a concern, because again, when we read books, we bring in those language skills. We look at things like inference and sarcasm and being able to read kind of those social pragmatics, even in the reading that we're doing. So we want to make sure that we're not missing something that a kid can get support in the school for. Again, like I said, there's not a huge pattern. There's not a particular risk. It tends, again, to be more related to the individual's interests and what their cognitive profile is. The big one a lot of parents have questions about is ADHD. So ADHD, there's 3 different types. There's predominantly inattentive, predominantly hyperactive and impulsive, and then a combined type that is both. So in the past, prior to 2013, a child could not be diagnosed with autism and ADHD at the same time. It was thought that kids with autism could not have ADHD. Recent research is that's not true. So now kids can be diagnosed with ADHD and autism. There's recognition now that kids with autism don't always have to have behavior problems. And that's kind of a newer area of research that people are kind of recognizing that, there may also be these other behavior disorders kind of going on in the same time. So again, it's pretty underdiagnosed because there's a really hard time differentiating the symptoms of autism from ADHD. So for example, a kid who that overlap kind of comes out. So if a kid who avoids your eye contact, pretty common in a child with autism, also very common in a kid with ADHD. They're avoiding your eye contact because they're looking out the window, they're distracted by their environment, they're having a hard time maintaining that eye contact, but not necessarily because they're avoiding it, they're just really distracted. But how can you tell the difference? That those are really hard and really kind of sensitive areas. Social difficulties are common in both ADHD and autism, obviously, and just generally kind of poor self-regulation. They're both neurodevelopmental disorders. So they're both going to kind of come and be predominant during the same part of life. But it's important for testing to distinguish those features. So inattention and impulsivity kind of can be a part of autism because, maybe they're distracted by their special interests. If they're really into trains and your child gets distracted because they're really focused on trains, that's more of a symptom of autism, not necessarily ADHD. Again, distractibility isn't just something that only happens with restricted interest. It could be other areas as well. Sensory seeking behaviors can often mask things like fidgeting and having a hard time sitting still. Processing problems in general, being kind of a slow processor, having that difficulty with focusing over time, that sustained attention piece. So again, that's the importance of testing, is that we can kind of piece out these individual areas so that we can make sure that we're not missing something. Because again, it's estimated about 40 to 50% of children with autism do have ADHD. And it's one of the most underdiagnosed in terms of diagnoses for kids with autism, but it can be a really big part of treatment that, if your kid's in therapy and they're having a hard time focusing, they may be missing really important parts of therapy and not necessarily getting the most out of the therapies that we have them and that we know work. So it's really important to look at kind of that piece as well. I wanted real quickly just to touch on some of the common medical diagnoses. I know you guys have an epilepsy presenter soon, so I won't spend a ton of time on this. So 25 to 40% of children with autism do have a seizure at some point. So it is one of the higher risk kind of medical diagnoses that are secondary to autism. So epilepsy is considered when there's more than 2 seizures. So I'll kind of focus more on just general seizures, not any specific epilepsy syndrome. Risks include an intellectual disability, having an underlying neurological disorder like cerebral palsy, or any family history of seizures. What the signs are, a lot of times there's a couple different types of seizures. So you can have, like I mentioned, you can have absence seizures, which are kind of staring spells. So it's having a seizure, but there's no motor component of it. It's just kind of looks like a staring spell. So again, is that attention? Is that having an absence seizure? Is that part of the symptoms of autism where the child is just not engaged with their environment? That's, again, the importance of looking at that, having this data to make that decision. There can be the stiffening of muscles, so kind of a rigidity piece, and that's kind of the tonic part of a seizure. And so that rigidity and kind of stiffening of muscles, is that a complex mannerism associated with autism? I don't know. It could be a seizure. It could be a repetitive behavior. The involuntary jerking, so the more classic seizure activity where they're kind of actively seizing and kind of having this jerky movement, is the clonic part of seizures, but not all seizures have that. So again, there's a lot of different, even just any changes in alertness, there's something called a drop seizure where kids just kind of lose all muscle tone for a second and then kind of are able to come back soon. Any sort of regression in development, because you can have seizures at nighttime as well that you would never know about. So just something to keep in mind as parents. Obviously, I don't mean to like scare anybody, but I think it's important because seizures are also going to impact cognitive development. They're also going to impact progress in treatment because repeated seizures, untreated repeated seizures do have kind of, like I said, I have a special interest in complex medical presentations, and repeated seizures or untreated epilepsy can have impacts in the sequelae in terms of your neurocognitive development. So if you do have concerns about autism, the next steps would be seeking a neurological appointment. So talking to your pediatrician, getting a referral to a neurologist. Usually you undergo like an EEG, some sort of imaging testing to look and see if there is seizure activity, often treated with medication very successfully. So it's one of those things that we have a lot of medication options that we can do. There's other, vagus nerve stimulators. There's a lot of treatment options that you guys have in terms of treatment, and it responds really well. But we just, again, want to be mindful of it as we look. So in terms of neuropsych testing, often we will monitor things and see if we have any concerns with seizures, just to make sure that there's another set of eyes on your kid, making sure that we can be aware of these things. Another area, so 50 to 80% of children with autism have sleep concerns. It's 2 times more likely in children with autism. So the general population, 25 to 40 or so % of kids do have some sleep issues at some point. So it is double the risk for kids with autism. You can have difficulties with falling asleep, you can have difficulties with staying asleep, or you can have kids who are just chronic early risers and wake up at 4 o'clock every morning and spend 2 hours kind of building, towers in the living room by themselves. But again, having this disrupted sleep pattern is going to affect their daytime functioning. As we know, when we, even as adults, have poor nights of sleep, it makes it hard for us to focus. It makes it hard for us to engage in different activities. It makes it hard for us to regulate our emotions. So another big part of that neuropsych testing is, before we jump to the conclusion that there's an attention issue or there's an emotion issue, we want to talk about, how's the quality of sleep? How are we making sure that, are they getting, the recommended number of hours of sleep? Is it disrupted? Are they sleepwalking, sleep talking? Are they getting up in the middle of the night for 2 or 3 hours and having any of those issues? A lot of times this can be related to kids with anxiety can have a hard time falling asleep because they're so focused on their anxious thoughts. Kids with ADHD sometimes have a hard time settling down at night because they're pretty restless. They tend to be pretty restless sleepers and they can wake up during the night. Sometimes kids with anxiety, depression have nightmares or wake up throughout the night, even if they're not able to verbalize them to you. Something like a night terror can be incredibly disruptive to a kid's sleep schedule. So the next step in terms of concerns with this is, again, either a referral to neurologist, developmental pediatrician, some sort of sleep expert. You can do sleep studies. But general, also the first area that we would look at is just to talk about general sleep hygiene. The typical no screens before bed, limit water intake before bed. So talking about just general sleep hygiene and what kind of behavioral can we do to make this routine easier for you guys as a family. So one of the areas I wanted to talk about was GI issues, so gastrointestinal issues. So it may or may not be related to some of the, sensory or restricted diet that sometimes some kids with autism have, reluctance to try new food. I'm only eating brown foods. No vegetables will ever touch my lips. So a lot of times there is this limited diet that kids with autism experience, and it can throw off your GI issues, lack of fiber in your diet, not getting enough of your vitamins, having a tendency to snack as opposed to eat full meals. So you're kind of never feeling that feeling of hunger. So those are all kind of related to some GI issues. Up to 85% of kids with autism at some point have a GI issue. So this can be things like chronic constipation or conversely diarrhea, enuresis or encopresis, which is wetting yourself or having bowel movements not on the toilet, or having even daytime or nighttime issues with just kind of potty training in general is a big one. A lot of times kids with autism don't have really great self-awareness or bodily awareness, and they don't necessarily pick up on some of the internal cues of, I have to go to the bathroom now, or I'm thirsty, I need to drink water, and they aren't aware of those internal bodily sensations. And so a lot of times there's concerns. Are they dehydrated? Are they not recognizing when they have to go to the bathroom, and then things are these last minute emergencies? Or are they getting so hyper-focused in some of their restricted interests that they're not paying attention to their body, and then suddenly they have an accident? So a lot of times that can be a concern. Kids with autism also have a higher diagnosis rate for GERD, which is the gastroesophageal reflux disease. So this is just a chronic inflammation, kind of acid reflux. So we're not sure why. It seems to be related to kind of the sensory and diet issues. There's some new research that's not necessarily new research that's really new, looking at kind of the gut bacteria in kids with autism and looking at whether they have a different kind of gut flora and bacterial flora within their gut system that we want to monitor. So then looking at food, because again, when we're hungry, when we're constipated, when we're having a hard time just with these basic bodily functions, we're going to be more irritable. We're going to be having a harder time focusing. So these are really important. Again, some signs to keep out for any changes in behavior in terms of refusing to go to the toilet, talking about any pain during toileting, physical signs of pain, grabbing your stomach, frowning when you're going to the bathroom. Any obviously vomiting or pain during eating is a big one. If kids are refusing to eat certain foods because it's giving them acid reflux, even if they're nonverbal, they may just kind of refuse to eat those foods as well. Additionally, something as part of this, kids with autism are 5 times more likely to have obesity concerns, because whether, again, it's related to these limited diets, I only eat bread and carbs is a typical one. So that increase in caloric intake can be a big piece. Also, kids with autism tend to have a preference for screens over physical activity. there's not necessarily the same like joining a sports team, running around, kind of getting those behavior pieces. So it's really important that we monitor that, and we're not looking at obesity concerns as well, because that can influence some of our behavior as well. So I want to make sure we have time for questions. So you guys are welcome to unmute yourself and ask a question. Also, I'll try to keep a look at the chat function and see if if you guys have any questions, feel free to type them out and I can answer them. But otherwise, if you guys do have questions that are specific to your child, or you don't feel comfortable asking now, don't hesitate to reach out. I put our website and our phone number up there. You can always reach out to me specifically, or generally our neuropsych department. There's a couple other neuropsychologists, and we all have kind of our own unique specialties. And so if I can't answer it, somebody else will answer it.